It's U of L Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome back to U of L Today with Mark Hebert on 93.9 The Ville. So glad you're joining us today. Hopefully you'll stick around for the next half hour and learn something about what's going on at the University of Louisville. On the show today, there's a new non-opioid painkiller that you've probably never heard of, but is being abused. Rachel Vickers Smith from the School of Nursing will be here to talk about the dangers of Gabapentin. She will also discuss her study on suicide and what time of the day is most likely for people to die by suicide. But first, 32 states have legalized the use of marijuana for medicinal purposes. 10 states have legalized recreational use of pot. So is there any difference in the chemical makeup of medicinal versus recreational marijuana? Dr. Murali Kolikonda is a resident in the neurology program at U of L. He's the chief resident in the neurology program, and he's studying these marijuana issues. Dr. Kolikonda, appreciate you being on the show.
Well, thank you for having me here. And this is a very important question. And we have to really know the definitions of recreational marijuana and medical marijuana.
All right, so what are the definitions? What's the difference?
So the most important thing I would want everyone to know is there are so many chemicals in the plant that we get all these products. One is delta-9 tetrahydrocannabinol, which is a very
easy for you to say. What is it?
It is called THC.
Oh, THC.
Yes.
Okay, well, I know what that is. Okay.
Yeah, and which is a psychoactive component. Mm-hmm. And there's another thing which is cannabinoid, which is CBD, popularly known as. And these are important. There are two main important components that everyone should know. And
the THC makes you high.
And CBD is a non-psychoactive component which has a lot of medicinal values.
Okay.
And recreational marijuana has a lot of THC and very limited CBD. And medical marijuana that is more popular and which is legalized in 33 states in United States of America, I think it has a lot of CBD, which has more medicinal values than THC. And there are a lot of studies and there are a lot of FDA-approved drugs which has a lot of CBD than THC. And this is the most important distinction that one needs to know whenever we are using terms like recreational versus medicinal marijuana.
Okay, so I think Kentucky is even going to be considering a medicinal marijuana bill coming up in the legislature in 2019, and so even Kentucky, which we're always behind on everything, is moving towards potentially approving medicinal marijuana. So what you're saying about medicinal marijuana is its chemical makeup is quite different from what folks on the street or in their own homes are smoking, right?
Yes, it's absolutely. It's completely different, and it has different composition, and it acts on different receptors, different receptors on the human brain and human body.
Okay, and when we're talking about recreational marijuana, and you said 33 states, it's 33 states that approved I'm sorry, I think 10 states have approved recreational marijuana. Do you think, folks, is there that perception out there that recreational marijuana, you can use that to get rid of your back pain too?
So this is a very important misconception that people get into, and they think I'm using CBD, but they're not really using CBD. They're using marijuana from the street, and they think it is used for my back pain, and it is used to treat my seizures. So whatever we get from the street will only make you high. It is not going to treat your back pain. It is not going to treat your spasticity, in patients with multiple sclerosis that some people use it, and it is not going to treat your seizures. So whatever you get in the street is not the medication that you need to is not the medication at all. I mean to say, so this is not going to treat your back pain. It is not going to treat your anxiety. It makes only high. It makes you only high.
And that's all it does, which to some people that's just fine, right? But if you got some back pain and some other things you're trying to take care of, it's not going to help you.
That is true.
Okay, so don't go by your dealer down the street's not going to help you, like you said, get rid of the back pain, right?
Yes, that is a very important burning issue right now, because in my clinic, people come and they say okay, for my seizures, I want to use marijuana. And they say, I want to use CBD. And there are a lot of studies that need to be done to really say this is approved for particular seizures. So I think this kind of common misconception, people think marijuana in the street can be used to treat seizures, which is wrong.
Right. We're talking with Dr. Murali Kolikonda, who's a resident, the chief resident in the neurology program at the University of Louisville, and he's been studying these marijuana issues that actually the whole country is talking about. I think even voters in 3 or 4 states went and approved medical marijuana in the last election. Let's talk. I want to talk about CBD oil, and we'll do that after the break here. But I do want to talk a little bit more about the marijuana and what folks should learn and how it impacts their bodies. So if I'm recreational marijuana with the THC, what are the receptors and the things in my brain that it's impacting versus what medicinal marijuana is affecting?
So there are like different receptors in the brain, which is called like the whole human body has like endocannabinoid system, and which is influenced by different receptors in the brain, which we call like CB1 and CB2. And THC, which is like tetrahydrocannabinoid, which is more psychoactive, which has more affinity to CB1, which is more predominantly in neurons, in hippocampus, and prefrontal cortex, like it's all over the brain. And CB2 is more on immune cells, and THC has more affinity towards CB1, which is kind of like is more psychoactive, which makes you high, and CBD has very low affinity to these receptors, and which modulates at different levels, and it has more anti-convulsant effect. I mean to say, it has more potential to reduce your seizures. But THC, which more acts on CB1, which is more, which makes you high, which causes like a lot of abnormal tuning of your brain circuits.
Okay, and so what are the effects of when I smoke marijuana? What are the effects on me? I mean, most folks like to get high, but what does that mean in medical terms?
So in medical terms, it influences your memory, attention, and your judgment, like your decision-making capacity. And there are like enough studies to say, like, we have like your brain, like we have a prefrontal cortex. Like there are like so much tuning happens during adolescent age when you smoke marijuana, which is more THC, which kind of like has abnormal tuning of your brain circuits, which will impair your memory, attention, and concentration. And later in your life, you'll kind of have more disability, and which people do not realize. And I really want to like emphasize that.
All right, well, let's talk a little bit about medicinal marijuana. What's been approved by the FDA? What if I'm in a state, they've approved it, what can I get?
So there are very few oral medications, which are oral cannabis derivatives, which are approved for, which are FDA approved. And one of them is like Medicinal, which is basically approved for cancer pain. People who get
That's a pill? As in pill form?
That's in oral form. Like it's like an oil form, and it's more like approved for cancer pain, who have like chemotherapy, who have like nausea, who have vomiting. So it's basically approved for that. And there is an important medication that everyone it's recently FDA approved, which is called cannabidiol, which is Epidiolex, which is approved for it is approved for 2 syndromes in children, which is very refractory epilepsy patients, which are Lennox-Gastaut and Dravet, which are very
epileptic.
Which is
epileptic seizures.
Yeah, which are very refractory epilepsy syndromes in children, and these are approved for age greater than 2 and older who have these refractory epilepsy patients, and they have shown that there is a reduced seizure frequency in these kids.
So there have been studies that show it works in little kids, that the cannabinoid oil does work in little kids that have epileptic seizures.
Those kids who are very refractory, and
what's that mean? What's refractory mean?
So refractory means like people who have used more than 2 seizure medications or more than 3 seizure medications, and they're yet not seizure free. And
so this is a last ditch,
yes,
last chance to stop the seizures.
And more importantly, these syndromes like Lennox-Gastaut, and they are very bad seizures in a kid. And for them, like they're already on multiple medications, and they have proven that like if the seizure frequency is 100, like after using this, and the seizure frequency has gotten down to like somewhere around 50 or 10, so which has shown some benefit, and that is FDA approved, and they have like a lot of studies. I mean, a lot of studies yet to come to see like its use in various other syndromes and various other purposes.
All right, so there's still some studies going on cannabinoid oil, right?
Yes,
and what else it could potentially be used for.
So there are like more other sister compounds which are like as cannabidiol. There is another thing called cannabidivarin, which is which is a sister component of cannabidiol, which has similar effects as cannabidiol. They have been like studying this in kids with autism, kids with epilepsy, and so there are other components which they are studying, and they wanted to like see the efficacy, safety, and tolerability of all these medications.
And how does the cannabinoid oil get in your system? Do you drink it? Is it syringe? How does it get in?
It's an oil-based formula like what we get, and you just like it's an oral medication. It's like oral medication. You don't inject. It's an oral formula-based medication, which is basically oil, and which has like some kind of constituents which you need to like take it as prescribed.
Talking with Dr. Murali Kolikonda from the University of Louisville. He's in the neurology program at U of L, and he's done some studying of these marijuana issues, both the medicinal and recreational marijuana, and the difference between the two. For the folks who are taking this or are giving this to their kids, are there a lot of them, or are we talking just a small pool of children worldwide that are using cannabinoid oil to treat their epileptic seizures?
So these are the CBD oil that we are talking about, which is FDA approved. These are only approved for only two conditions, like two refractory epilepsy
So that's
conditions.
a small pool.
But like even adult people are asking for this CBD oil, and most of the people are using it. Approximately 20% of epilepsy patients are actively using this.
Already?
Already.
Even if they're not in a state where it's medicinal marijuana is approved?
Yes. I mean, even it is not approved, 20% of the epilepsy patients are active users. So which makes me think people do not know the formula, people do not know the drug interactions with other medications, and they don't know like what quantity of THC or CBD are they getting. So which is a very huge impact. Like it impacts their seizure frequency, it impacts their, it interacts with other drugs. So I think this is the most important thing to discuss, that it is not FDA approved and there are no controlled studies still. It's still evolving specialty. And I think people should be careful in using this with CBD oil.
So when people see the ads on the internet or they hear the ads on the radio and they say, cannabinoid oil, it'll help treat your ailments, order some today, what should they think?
So this is like completely, I think people should be aware of what CBD oil they are getting and what it is FDA approved for. And they also need to know like what studies are done. And at this time, at this point of there's a huge paradigm shift from Charlotte's Web. That is how this is being like discovered. Like till now, I think there are a lot of studies, yet it is in the preliminary phase where we don't have efficacy, safety, and tolerability of CBD oil, and we don't have good understanding of drug interactions. I think everyone should be cautious, and I would suggest like people should discuss, and there should be a shared decision making with their physician. And there's a knowledge gap between physician, patient, and families who thinks that CBD oil or marijuana is the cure for all ills, which is not true.
And if you're giving cannabinoid oil to your child who is going to have one of these two epileptic type seizures, and it's a last resort, is there a possibility that cannabinoid oil can cause brain damage to children? I mean, we know that recreational marijuana, and there's been studies that show recreational marijuana can have an impact on the brain development of children, but can CBD oil have the same detrimental impact on brain development or not?
So yet there are like a lot of studies to come. I mean, there is no clear evidence that CBD oil has these harmful effects, but yet it has some potential side effects with acting on different receptors. It is a CB2 or CB1 which acts. So there is definitely a lot more studies need to be done. As of now, like we have some potential effects like dizziness and nausea and intolerability and drug interactions. And there are like different seizure medications that it interacts with. So that people need to know. So no drug comes without any side effects. That is what I can say.
Right.
So.
But ask your doctor, I think is what you're saying. If you're a parent out there who has a child, or you're somebody that wants to get marijuana to treat your back injury, talk to your doctor first. Even if it's illegal in the state, they're not going to turn you in, right?
That is true. Like I would want like to talk to your doctor first and see like even the dispensaries what people are going to. They need to know like what they're getting into.
All right. Dr. Murali Kolikonda, it's great to see you. Thanks for the info. It's very interesting. Good
Thank
stuff.
you. I would like to want to bring one case
Okay.
which really moved me and about this. So there is this patient that there's a 13-month-old kid who came to our clinic and who came to the emergency department actually, and she was found like lethargic. She was not like responding, and there was marijuana in her system. So this brings a point that it is so rapidly like people are like having access to it, and we call it as accidental ingestion. But in fact, like it seems like she has ingested somewhere, and you don't expect like 13-month-old kid to have ingestion of this marijuana.
So the parents may or may not have given it to the child to try and cure something, and
So this is
she
a
had an
completely a
overdose.
normal child. The
Right.
mom was abusing it. So this is kind of a thing which everyone needs to pay attention to.
Pay attention to. All right, there you go, parents. More with Murali Kolikonda. Appreciate you being on the show. Our next guest is Rachel Vickers Smith, who is an assistant professor in the U of L School of Nursing. And we're going to talk to her about a couple of research topics. One, suicide among alcoholics, and two, a painkiller called Gabapentin, which I have never heard of. Rachel, good to have you on the show.
Thanks for having me.
What the heck is Gabapentin?
So, gabapentin is FDA approved as an anticonvulsant, so for people who have seizures, and it's also FDA approved as a pain medication for the pain that lingers after you have the shingles virus. So, those are its two FDA indications, but it's prescribed off label for about 83 to 95% of its usages. So, it's also prescribed for mood disorders, helping people sleep, other types of pain. I've heard it used for diabetic neuropathy quite a bit. Its brand name is Neurontin, so that's another.
Brand name is Neurontin, so it's on the
Neurontin.
shelf, is that right?
Yeah, yep. It's
Although
now
it's not over the counter, obviously, but it's
Right.
prescribed.
Yep.
Okay, so that's what you're looking for. All right, so what's the problem with gabapentin?
So we historically thought that gabapentin had no abuse potential, and what we've found recently in maybe the past 5 years or so is that it actually does have abuse potential, particularly with those who have a history of substance abuse. So it's prescribed frequently for pain, and what we're finding is that most of the time it's fine for people to use when it's used as prescribed. It's very safe. It can be effective for the indications that that it's being prescribed for. But for some people, it does cause a problem and can have some addictive properties.
Mm-hmm. And you did a study, in 2015, I think, the first really big study of the gabapentin, right, and the potential abuse?
Yeah, it was the first epidemiological study on gabapentin abuse in the United States. And we found that, for one thing, we found a nearly 3,000% increase in the number of people who said that they misused gabapentin for the purposes of getting high from 2008 to 2015. And that kind of coincides with the crackdown on opioid prescribing. So as we've seen a crackdown on opioid prescribing, we've seen more gabapentin prescribing, and this has kind of followed along with that. There definitely has been an overprescribing of gabapentin, and so it's been in the hands of more people.
Right.
And so we found that really in the general population, there's about a 1% prevalence of gabapentin misuse. But among those who are substance misusers, it's about 15 to 22% have misused gabapentin.
So the chances are, if I'm using heroin or opioids or something else, I'm probably also, adding to my repertoire with gabapentin as well?
Right, yeah. So we found a lot of times that people were mixing gabapentin. So by itself, it doesn't really have the...
Doesn't get you high?
Doesn't get you high. It doesn't give you the feeling that you want. But when people mix it with their, let's say, Subutex or buprenorphine, which is an opioid detox medication, or with caffeine or alcohol or things like that, heroin, it potentiates the effects of those drugs and can even be lethal.
Wow. So it has killed somebody, or you got to have the mix to have a problem with the potential of death?
Right, yeah. So in both Jefferson County and the state of Kentucky, we found in overdose reports that gabapentin was found in about a fourth of the fatal overdose deaths. So it's not by itself causing these overdoses, deadly overdoses, but when it's mixed with something, it can definitely slow breathing, stop the heart, things like that.
We'll talk some more about that in just a second. We're talking with Rachel Vickers Smith, who's an assistant professor in the U of L School of Nursing. We're talking about her study on the painkiller Gabapentin, which, again, I had never heard of until I corresponded with Rachel about this show. Do you think folks have any clue what Gabapentin can do?
I think they're becoming more aware. I think that was the big issue, is that it was actually marketed off-label, and doctors presumed that it had no abuse potential because that's what they were educated about the drug, that it had no abuse potential. So I think since we've started talking about this, and also since Kentucky scheduled the drug last summer, I think people are becoming more aware. And so that's what we really want, is for prescribers to be aware of the abuse potential and not stop prescribing it altogether, because it definitely has some use and can be very beneficial for people. But we want them to have all the information when they're prescribing. And so they can say, is this the best drug for this particular person? Or should I maybe try something else?
And Gabapentin, again, going back to what you talked about earlier, is mainly prescribed for people that suffered from shingles. Is that the main
So
use
that's
for
what
it?
it's FDA approved for, but actually 83 to 95% of the usages are for non-FDA indications. So for other types of pain, diabetic neuropathy, back pain, mood disorders, things like that. So most of the time people who are getting a prescription for it are not getting it for an FDA indication.
Is the use of that drug and the prescribing of that drug going up, down, flat?
We've seen it increase over the past couple years, and I think with the crackdown on opioids, and actually the CDC recommends it as an alternative to opioids, recommends using gabapentin as an alternative. So I'm sure we're still seeing an increase in prescribing, but hopefully with the scheduling of it, we'll see it kind of start to plateau and maybe even decrease a little bit, so that we're really just prescribing gabapentin for the individuals who it's best suited to treat.
And again, if it's taken at normal, like you're supposed to, the dosages that you're supposed to, and you're just taking gabapentin, it's not a problem. But if
Yes.
you're mixing it with something else, that's when it can lead to death.
Exactly, yes. By itself, gabapentin is relatively benign. It doesn't have a lot of side effects. And what we also see is people who are misusing gabapentin are using it outside the therapeutic dose. So a lot of them are using far more than what their prescription is or what anybody would be prescribed. And like you said, they're mixing it with other drugs, and that combination is what causes the fatality.
But it doesn't get you high on its own.
Unless
Unless you take a lot of it,
yes,
right?
Yes. Yeah, you're likely, if you're taking the recommended dose, you're not likely to experience a high from gabapentin.
Okay, well, that's interesting. So the final word on this to doctors, pharmacists, and to people at large is what on gabapentin?
Is that work with your doctor to make sure that it is the best medication for you, and for doctors to just be aware that it does have abuse potential for certain populations, and just be aware of that when they are prescribing.
Okay. Again, we're talking with Rachel Vickers Smith. She's an assistant professor in the U of L School of Nursing, and she's been working on a couple of studies. And the one we're going to talk about now is suicide among those who are drinking a lot, among alcoholics. Is that a fair assessment?
Yeah, people with alcohol dependence.
Okay. So what'd you find? What was the study? What'd you find?
Sure. So, well, we know suicide is the 10th leading cause of mortality, and its incidence is actually increasing. And there can be multiple risk factors for suicide, such as unemployment, history of suicidal ideation, psychiatric illness, chronic medical illness. And we've also found that a third of suicide victims show evidence of recent drinking, and oftentimes heavy drinking. And by heavy drinking, we're talking about more than 5 drinks per day, more than 5 days in a month. And this pattern is often found among alcoholics. And so what we also know is that time of day can impact when suicides happen. So a lot of times suicides are times when people are alone. But this hasn't really been studied among alcoholics very much. And so that was what this study set out to do. So we used this national database called the National Violent Death Reporting System. And we were looking for periods of increased vulnerability for people with alcoholism. And what we found was that for alcoholics, the primary, the peak incidence of suicide was around 9 p.m. And for those who were intoxicated prior to death. For those who weren't intoxicated prior to death, it was around noon.
So those who hadn't been drinking on that day, chances are, well, the average time that they would kill themselves was noon.
Right.
But for alcoholics who are drinking and they've been drinking all day, perhaps 9 o'clock was the time that they were most likely to commit suicide.
Correct. Yep. And we know that people are more likely to drink alcohol in the evenings, and this can predispose them to impulsive behavior, suicidal ideation. And so it's important to understand when this group of individuals may be the most vulnerable in order to really set up a plan. So if someone is drinking, someone who has a history of alcohol dependence, they're drinking late into the night and they start feeling suicidal ideation, it's important to have a plan in place that they know who they can call, they know they can talk with their family, their friends, care providers, so that they can reach out and say, I know that these people, regardless of the time of day, will be there to help me walk through this.
And that's why that study is important. So
Yes.
family members recognize perhaps, hey, John over here is going down a hard road. He's been drinking a lot.
Right.
I wonder if he's at risk for suicide.
Exactly, yeah. And so, a lot of the places, a lot of the care facilities might be closed that they would normally go to. And so that's why these 24-hour hotlines are also so important, that we make sure that people who are highly vulnerable in the evening when they're alone can get the help that they need.
And of the, and you may have hit on this earlier, of the suicide, I'll call them victims, that people that partook in suicide, those folks, how many of them had been drinking? When you take the total number of suicides happening in the United States, how many of those folks had been drinking before they did suicide?
I think it was between 40 and 60%.
Really? So about half. So that's a bunch. And
Yeah.
and those folks, is that from your research and your study, is it liquid courage? Is that what it is? Is it?
I don't think we know that. I think that for some individuals, this may be a pattern for them. If they already are alcoholics and they're actively drinking, they're not in recovery, then this may be, that this is kind of their pattern. They come home, they drink, or maybe they've lost their job and they're drinking during the day. And for some people, it may be kind of more of a one-time type of thing, but
that's unlikely, isn't it?
I think so. Yeah.
I mean, you're in nursing and I'm in communication, so we're not psychologists here, but you would think folks had been thinking about this for some time and finally just hit the end of their rope, and a few drinks later, they did.
Right. Yeah, it definitely can lower your inhibitions, which anybody sees that who has had alcohol. It definitely lowers your inhibitions to do anything, really, and everyday things. And so for those who may have a higher likelihood of committing suicide, it can lower their inhibition and facilitate their ability to do that.
Yeah, but you couldn't figure out in your study why the 9 o'clock hour versus the noon hour was more prevalent among folks who drank, right?
No, we really couldn't figure that out. It could be due to some people are at work during the noon hour. For those who are employed, they don't have that opportunity to commit suicide during that time. Whereas those who are employed, it may be later in the day that they start their drinking.
Yeah. All right. Any more studies on that one coming down the road, or you?
Yeah, we're actually looking at repeating the study, but within veterans, because that's also a population that's at high risk for suicide, and so we would like to identify times of day that they may be particularly vulnerable to get some prevention efforts out for that.
And that may be good for folks at VA hospitals and treating the veterans to know here's what to look for and here's what times to look for, right?
Right, exactly.
That's the whole idea. Okay.
Yeah.
All right, Rachel Vickers Smith, assistant professor from the U of L School of Nursing. Appreciate you being on the show. It's good to meet you. Thanks for listening to U of L Today with Mark Hebert, and go Cards.